Hello and welcome back to your own teleconferencing program, which is jointly conducted by Indira Gandhi National Open University and National Board of Examination. The time by our studio clock is 3:30 in the afternoon, and this program is specially meant for DNB students. This program is based on 5 sessions, and this is our second session of today's program. The topic of this session is management of stable COPD, and the expert of our today's program of this session is Dr. Deepak Bhattacharya, who is a chest physician in Pulmonary Critical Care Medicine, VMMC and Safdarjung Hospital, New Delhi. If you want to ask any queries about management of stable COPD, you can use your phone numbers. Our phone lines are open for you. The numbers are 011, which is our STD code, and the numbers are 29532844, 29532845, and toll free number 1800112345. Before handing over the session to Dr. Bhattacharya, I would like to give you one more information for the CME workshops for DNB students and consultants. In order to sensitize the DNB students and consultants, some CME programs would be organized, and these programs are CME programs in preparing for theory examinations, CME programs in preparing for practical examinations, CME programs in preparing for thesis research methods, CME programs in clinical and surgical skills for DNB candidates in surgery, OBG, orthopedics and anesthesia only, and CME workshops for consultants on bedside teaching, research methods and evaluation. The concerned students and consultants are required to apply for these CME programs immediately on the registration format available on the website, along with the registration fee by 28th February 2009. If you want to know the centers for CME programs and workshops, I would like to tell you the centers would be in New Delhi, Chennai, Hyderabad, Bangalore, Kolkata, Calicut and Pune. And the topic of our next week's teleconferencing program would be radio diagnosis and neurosurgery. That would be held on 12th of February 2009, next Thursday. And to get the forms of National Board of Examination, you can download our forms from our website. The website is www.natboard.edu.in, www.natboard.edu.in. And to get the DVDs of our teleconferencing programs, you can contact National Board of Examination. This program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. And right now I would request to start the program to Dr. Deepak Bhattacharya. Dr. Bhattacharya, please.
Thank you, ma'am, and welcome. Good afternoon to all of you. I'll be speaking today on treatment of stable COPD. Now, my work has been made a lot easier by my previous speaker, Dr. Chakravarti, who has discussed a lot of the topics on which also I will dwell on briefly, so that for the sake of completion of the topic. There will also be a number of slides in my presentation which I will not go into the detail therein, because some of the subsequent speakers in today's topic, because today we have taken up the topic of COPD and tried to discuss it at length. Therefore, subsequent speakers will be dwelling on those topics. Therefore, I will inform you as we come to them about whatever is to be discussed later. So, we will go on straight away to the subject. Now, I will again go to the definition of COPD. Dr. Chakravarti had showed you a definition from the Gold Guidelines. This is the definition as defined by the ATS. Primarily, all of the definitions are basically same. The definition is very important with respect to the treatment, because there are salient features which are mentioned in the definition, which are important to point at and to target when we are thinking of treating a patient of COPD. The first thing they have said, it's a preventable and a treatable disease. Second thing, that it is not fully reversible. The third thing, that it is an inflammatory disease. And the last of it, it also produces systemic consequences, and it is related to cigarette smoking. Therefore, our treatment would be based on looking at these parameters and trying to find out methods to treat these problems. Now, in the treatment of COPD, there are basically four components. The first is to assess and monitor the disease. The second is to reduce the risk factors. In the management of stable COPD, primarily it is education, which would also include, to a certain extent, smoking cessation and rehabilitation, pharmacological management, certain non-pharmacological managements, and the treatment of exacerbations. Now, in the management of COPD, the first step is to assess and monitor COPD. Again, some of this has been discussed by Dr. Chakravarti. The diagnosis should be considered in any patient who had dyspnea, chronic cough or sputum production, and with a history of exposure to the risk factors, primarily smoking. The diagnosis should be confirmed with the spirometry, and as I said, the post-bronchodilator FEV1 by FVC should be less than 7.7 per, which confirms that the airflow limitation is not fully reversible. There are several comorbidities in COPD which should be actively identified. Now, in order to rule out other differential diagnosis, a chest radiography would be useful, and other tests to better determine the phenotype and physiological characteristics of individual patients. Again, the spirometry is very important, as discussed by Dr. Chakravarti. This shows in one graph the normal spirometry, which is the lower volume time graph, and the upper one is in that of a patient of a COPD, which is showing a decrease in the FEV1 by FVC ratio. This is also a very important slide, since our treatment is based on the severity of COPD. Therefore, we will again emphasize that in a mild, first thing in all of to diagnose a patient of COPD, the FEV1 by FVC should be less than 0.7%, which suggests that the obstruction is not fully reversible. Once the FEV1 is more than 80%, it is labeled as a mild COPD. Once this is between 50 and 80% of the predicted, this is labeled as moderate COPD. Between 30 and 50% of the predicted is labeled as severe COPD. Now, anything which is less than 30% of the predicted, or which is less than 50% or with chronic respiratory failure, is labeled as very severe COPD. And depending on the grade, we change or we add newer modalities in the treatment. Management of the stable COPD. Now, to reduce the risk factors, what are the key points? Reduction of the total personal exposure to tobacco smoke, occupational dust and chemicals, and indoor and outdoor air pollutants are important goals to prevent the onset and progression of COPD. Smoking cessation is the single most important and cost-effective intervention in most people to reduce the risk of developing COPD and to stop its progression. Now, I have given a list of the differential diagnosis, on which again I would not elaborate. I will just enumerate the differential diagnosis. COPD could be most commonly misjudged in a case of asthma and congestive heart failure. Since congestive heart failure also occurs in elderly population, therefore this is one differential diagnosis which must always be kept in mind. Bronchiectasis is still a pretty common disease in our country because of the continued prevalence of viral diseases and exanthems in childhood. Therefore, this is another differential diagnosis which should be kept in mind. Tuberculosis is one of the leading causes of death still in our country and must be always kept in mind while diagnosing a case of COPD. Obliterative bronchiolitis and diffuse bronchiolitis are also other diseases which could be misdiagnosed as COPD. Now, what are the goals of the COPD management? Varying emphasis with differing. There is a varying emphasis with differing in the severity. The first salient point is to relieve the patient of his symptoms. Second is to prevent the disease progression. Third is to improve the excess tolerance for patients, improve the health status, prevent and treat complications, prevent and treat exacerbations as and when they occur, and finally to reduce the mortality. In the management of COPD, as I said, smoking cessation is probably the single most important parameter which can be taken to treat COPD and to decrease mortality. There are only few modalities which have shown to decrease the mortality and to increase the lifespan. One of them is smoking cessation. Now, I will not dwell much on this topic, as Dr. Sen in one of the subsequent speakers in today's series of lectures will be dealing at length on this topic. Now, there are certain general principles that we follow in treating COPD. They are: the effective medications for COPD are available. We should not take a nihilistic attitude when we diagnose a patient with severe COPD. One should keep in mind that medicines are available for every stage of COPD, and all patients who are symptomatic merit a trial of drug treatment. Therapy with currently available medications can reduce or abolish symptoms, increase exercise capacity, reduce the number and severity of exacerbations, and improve health status. At present, it is seen that no drug treatment has shown to modify the rate of decline of the lung function. The inhaled route is preferred when both inhaled and oral formulations are available. Smaller doses of active treatment can be delivered directly by inhaled route with equal or greater efficacy with fewer side effects. Patients must be educated in the correct use of inhalers whenever these are used. Significant number of patients cannot effectively take the inhalers, and in these cases one must take the help of dry powder inhalers or of a spacer chamber. It is seen that compliance with treatment in COPD is high in most of the studies. That is because the patients as such are symptomatic. Now, one of the major modalities for treatment in a patient of COPD are bronchodilators, and mainly there are three broad categories of bronchodilators. They are the beta agonists, the anticholinergics, and the methylxanthines. Despite substantial differences in the site of action within the cell and some evidence of non-bronchodilator activity with some classes of drugs, the most important consequence of bronchodilator activity is airway smooth muscle relaxation, improved lung emptying during tidal breathing. The resultant increase in FEV1 may be small, but in a COPD, this small increase in FEV1 is very significant and decreases the sense of breathlessness to a large extent. In general, the more advanced the COPD, the more important the changes in lung volume becomes relative to those in FEV1. Now, as we have said earlier, nebulized drugs or inhaled medication is very good method of giving drugs in a patient of COPD. Therefore, drug delivery by MDI or DPI is always preferable. High doses of nebulized beta agonists and anticholinergics singly or in combination can be used in exacerbations of severe disease when the simplicity of administration is an advantage. Otherwise, in severe disease, limited data have failed to show any significant difference in exercise performance between drugs given by a nebulizer and by the spacer device. Now, these are broadly the three categories of drugs that we have spoken of. On top, we have seen that they are the anticholinergics, which act on the M1, M2 and M3 receptors. In the blue, we have shown the beta agonists, which act on the beta 2 AR receptor, and theophylline, which increase the cyclic AMP through phosphodiesterase. Now, coming to the drugs proper, the beta agonists, these are available in several formulations in our country, and they are of two categories broadly. One are the short acting, they are salbutamol, and presently they have now introduced what is levosalbutamol. This is the levo isomer or the R isomer of salbutamol. Now, most of the drugs that are available in the market have both the levo and the dextro isomer. They are racemic compounds, and it is seen that in racemic compounds, the dextro or the levo form, one of them is important for the positive effects of the drugs, and the other usually give rise to the side effects of the drugs. Therefore, if we can make a drug of the active isomer, that would decrease the side effects of a drug and improve the positive effects or the good effects of a drug. Therefore, levosalbutamol is the levo isomer of the drug salbutamol and has lesser of the side effects of the beta agonists. The short acting beta agonists have an effect of less than 6 hours or approximately 6 hours, and the long acting beta agonists have an effect of approximately 12 hours or little more. The beta agonist, long acting beta agonists available in our country today are salmeterol and formoterol. There are several oral medications which are also available. but it is preferred to use the inhaled route as far as possible. Coming to the pharmacology, beta agonist acts by binding to the B2AR receptor. It activates the adenyl cyclase via the signal G8 protein and causes a rise in the cellular cyclic adenosine monophosphate levels and activation of protein kinase A. Now it is seen that this it does through the smooth muscle kinase and through the calcium activated potassium channels, though in detail the action is really not known very clear to anybody till now. The difference in onset of action is related to the lipophilicity of each of these agents and their ability to activate the beta-2-AR in the aqueous phase, that is albuterol and formoterol. The majority of beta-2 adrenoceptor agonists, as we have said, are available as racemic compounds, and it is seen that the long-acting beta agonist especially can reduce COPD exacerbations in certain trials by 15 to 20%. Now there are several non-bronchodilator effects of the beta-2 adrenoceptor agonists. One of them very important are the inhibition of airway smooth muscle cell proliferation. The beta-2 agonists also inhibit inflammatory mediator release. They stimulate the mucociliary transport system. They have a psychoprotective action on the respiratory mucosa. They produce attenuation of the neutrophil recruitment and activation, and in combination with the inhaled corticosteroids have a additional effect. Now this is a diagram showing the mechanism of action of the beta-2 agonist. Now on top we can see that this is the receptor, and through the G8, this is a G protein receptor, and through the G8 it activates the cyclic AMP and the phosphokinase A, and it activates the action of the smooth muscle relaxation through a calcium activated potassium channel. Now as we have also said, the action and the onset and duration depends on the lipophilicity. The lipophilicity we can see here for salbutamol, it is a hydrophilic compound, therefore it has a shorter duration of action and is rapid in onset. Whereas for formoterol, they are intermediate in its lipophilicity, has a longer duration of action, but it has a immediate onset. Therefore it can be used at times in place of short acting bronchodilators, since it is seen to have its effect within 1 to 3 minutes. Unlike salmeterol, which is also a long acting beta agonist, but the onset of action is slower than formoterol, and it has a slow onset of action. Now there are certain side effects of the beta agonist, like in all drugs. The most important of these are those on the heart: palpitations and premature ventricular contractions relating to the stimulation of the beta-1 receptors in the heart. More and more drugs one is trying to manufacture with a more specific beta-2 activity. However, the beta-1 activity has not completely nullified till date. Tremor and troublesome symptoms are troublesome. This is also because of the beta receptors there in the muscles of the body, particularly evident after high dose nebulization. With the use of MDI, tremor can be reduced, since the total drug which is used is much less, and by the use of spacer chambers. Sleep disturbance appears to be worse if you use a higher dose. There are certain metabolic side effects which are there. Important among them are hypokalemia and increased resting oxygen consumption. The second group of drugs we come to are the anticholinergic drugs. Now these are certain drugs which are available only by the inhaled route. There is no oral form of these drugs, and in today's date there are two such drugs which are available in our country. The first one is Tropium. This is a short acting anticholinergic agent, and the second is Tropium. This is a long acting anticholinergic agent. Now the parasympathetic activity of the anticholinergics is in the large and medium sized airways, is mediated through the muscarinic receptors, as we had shown in one of the previous slides. There are three muscarinic receptors, M1, M2 and M3. Mainly the action of anticholinergics is through its action on M1 and M2. Although it attaches M1 and M3, although it attaches to the M2 receptor, it quickly dissociates from the M2 receptor, and the activity of the long-acting anticholinergics, that is tiotropium, maintains for as long as 36 hours, although there is a dip seen around 18 to 24 hours. Now, the anticholinergic agents also, they reduce the airway tone and improve airway limitation. They also reduce hyperinflation and therefore exercise capacity. The anticholinergics also have a few non-bronchodilator effects. They are, the anticholinergics contributes to reduce neutrophilic inflammation in COPD. Now, this is a diagrammatic view. On top you can see that this is the postsynaptic neuron, and the postganglionic nerve on top is the M1 receptors in yellow, the M2 receptors are seen in green, and right at the bottom next to the muscle, that is after the nerve endings, is seen the M3 receptors. And it is mainly the action on the M3 receptors where the long acting anticholinergics are effective. Now, this is another diagram which shows that it decreases the vagal tone on the airways, and once it attaches to the M3 receptors, the vagal tone is reduced, giving rise to increase to the bronchodilation. There are also a few side effects to the anticholinergics, although broadly these are a very safe group of drugs used by the nebulized route, by the inhalational route, and they are the drugs which are only available by the inhalational route. Now, the main side effect of these drugs are they can be troublesome in some elderly patients who have prostatic symptoms and in the presence of glaucoma. This is a drug which also produces dry mouth, and dry mouth is seen most marked in use with Tropium. There is a slight metallic taste after inhalation, which is more marked with ipratropium, caused by these drugs. As a reason initially this was only available as a dry powder inhaler rather than as a meter dose inhaler, but in our country now the meter dose inhaler has also been introduced, but it is a duty of all the physicians using this drug to inform the proper usage of this meter dose inhaler so that the drug does not go into the eyes. In a few cases, paradoxical bronchoconstriction has been reported in asthmatics, but it is not confirmed in COPD patients. The third group of drugs are the methylxanthines. These are rather weak bronchodilators, and the detailed action or the effect of these drugs and the method by which it acts is still today not very clear. They are a group of drugs which can be only taken by mouth, and there are no inhalational formulations of these drugs. This mainly includes theophylline, including aminophylline and its derivatives. Theophylline is a non-selective phosphodiesterase inhibitor and acts as a weak bronchodilator and a respiratory stimulant. It improves, very importantly, the diaphragmatic contractility. It also has anti-inflammatory properties and the ability of enhancing the effects of inhaled corticosteroids in patients with COPD with theophylline has an additional effect. Now, it is important, unlike what was thought earlier, to use a very high dose of theophylline, because we don't really depend on theophylline for its bronchodilator effectivity. Therefore, we tend to use a lower dose, and we manage the blood levels, which should be measured whenever suspected, at a lower dose, about 7 to 14 micrograms. Now, these drugs also have a few side effects, and usually the side effects keep on increasing with increasing blood levels. In slight increase in the blood levels, it will present as a headache, nausea, vomiting, diarrhea and heartburn, but as soon as the drug levels increase to more alarming levels, they would give rise to cardiac side effects like ventricular and atrial rhythm disturbances, and may even produce complications. What is another thing more important with this drug is the plasma levels of these drugs is decreased in patients who continue to smoke cigarettes, who are on anticonvulsant drugs or on drugs for the treatment of tuberculosis, especially rifampicin. Their drug levels are increased by in respiratory acidosis, in congestive cardiac failure, in liver cirrhosis, and if the patient is using or is being prescribed erythromycin or one of the fluoroquinolones, especially ciprofloxacin. Now, this is a diagrammatic view of the effect of the commonly used medications on important clinical outcomes of COPD. Now, on the top portion, one sees the various medications and the effect on the FEV1. Now, if we see, all of these drugs have a positive effect on the FEV1. On the lung volume, also all these drugs have a positive effect, excepting corticosteroids. Corticosteroids do not increase the lung volumes. But the dyspnea scale is improved by all these drugs, and also all these drugs improves the quality of life score, excepting the short acting beta agonists. Now the exercise endurance again is also improved by all these drugs. The disease modifier by FEV1, if one sees, is mostly very little with all these drugs. Mortality is also a parameter on which none of these drugs have its effect, and in the side effects it is seen that most of these drugs are very safe, excepting Theophylline, which can have harmful side effects in higher doses. Now corticosteroids, as we said, is not actually a bronchodilator, but it is an essential part in the treatment of in COPD, because in the severer forms of COPD, inhaled corticosteroids are being used routinely. And inhaled corticosteroids which are available in our country in today's date are beclomethasone, budesonide, fluticasone and cyclosinide. Oral corticosteroids have also been used in COPD, but their role is only in acute exacerbations and not in chronic stable COPD. Now coming to the pharmacology, glucocorticoids act at multiple points within the inflammatory cascade. Through their effects on COPD are more modest. Most studies have been performed using relatively high doses, and although they have shown a slight bronchodilator, this is not shown in the normal doses that one is used. And we should be aware that using very high dose of inhaled corticosteroids can have systemic effects because of the absorption from the pulmonary circulation. Corticosteroids also have a fewer side effects, although it is used by the inhaled route, especially if they are used more than the permitted levels, safe levels for the individual drug. And the most common side effects that are seen with inhaled corticosteroids are because of its local effects on the airway, that is oropharyngeal candidiasis and a hoarse voice. In few patients, spontaneous skin bruising has also been noted. Now the clinical outcomes with the use of corticosteroids in patients with more advanced disease, that is usually classified in a FEV1 as those having FEV1 of less than 50%, there is evidence that the number of exacerbations per year can be reduced by inhaled corticosteroid use in COPD patients. And evidence from 4 large prospective 3-year studies have shown that no effect of inhaled corticosteroids, there is no effect on the rate of change of FEV1 in any severity of COPD. Now if we compare the effect of short versus long acting agents in bronchodilation, now here is a graph which is showing the effect of the Tropium, which is a short acting bronchodilating agent, which is compared against salmeterol, which is a LABA, long acting bronchodilator agent. Now the lower graph is a placebo, and you can see the baseline at 0. Now you see that with the use of ipratropium there is a peak and a trough, whereas with salmeterol there is a gradual rise in the FEV1, and there is a sustained effect till about 12 hours. Similarly with Tropium, in this graph we see that the FEV1 gradually rises. In the third graph from the bottom, when compared to the placebos, it is seen that after use in 1 day there is a gradual rise, but after use for 1 year with every dose there is a gradual rise which sustains till 3 hours in this graph, and if seen can continue up to 24 hours. Now what is the effect on the lung volumes by these drugs? This is a study which shows the effect on lung volumes of Tropium versus placebo. Now it is seen that the Tropium increases the FEV1 in comparison to the placebo, whereas in the placebo it is near to 0, the increase in FEV1. In Tropium it is about 200. It also increases the FVC, it increases the inspiratory capacity. Inspiratory capacity has a great role in